طيب بسم الله الرحمن الرحيم. بسم الله والصلاة والسلام على رسول الله محمد بن عبد الله سيد الأولين والآخرين وعلى آله وصحبه أجمعين. اللهم لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. أما بعد، تحية طيبة يقدمه لكم فريق خدمات الأشعة بالتجمع الصحي بمكة المكرمة بقيادة سعادة الدكتور ماهر بن عبد الرحيم غزاوي، وبدعم ومساندة المدير التنفيذي للخدمات الطبية المساندة سعادة الدكتور فهد نوار الحارثي. السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا في هذا اللقاء المبارك الذي سيكون فيه معنا سعادة الدكتور حسين سالم برد، أخصائي أشعة بمستشفى خليص العام التابع للتجمع الصحي بمكة المكرمة، وذلك لتقديم محاضرة بعنوان فاست أبدومين ألتراساوند سكان. بسم الله وعلى بركة الله نبدأ. تفضل دكتور حسين.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته. تقدر تشير السلايدات يا دكتور؟
أيوة كده واضح صح؟
أي ممتاز، الصوت واضح، ممتاز، جزاك الله خير. على بركة الله دكتور.
السلام عليكم ورحمة الله وبركاته. Good evening everyone. I am Dr. Hussein Salim Muhammad, a senior registrar in diagnostic radiology at Khulas General Hospital under Makkah Health Cluster. I work closely with emergency and trauma imaging, and fast ultrasound is not just a topic for me. It is a tool I see influencing real decision in real patient daily. Today, I'm not here to overload you with theory. I am here to show you how fast ultrasound truly works when second matter. Trauma happens fast. It doesn't give warning. It doesn't wait for preparation. One moment, the patient is fine. The next moment, they are bleeding, unstable patient, and fighting to survive. In trauma care, the first few minutes matter more than anything else. And the question is not what is the perfect diagnosis here. The real diagnosis, the real question is what decision do I make right now for this patient trauma? The golden minutes here. A simple question. You are in the emergency room now. A trauma patient arrives. Blood pressure is dropping. No CT scan available at that time. You have 60 seconds just. What would you do for this patient? Fast ultrasound scan. What does it mean by fast? Fast mean focused abdominal assessment with sonographic in trauma patient. The indication and application of fast in acute blunt or penetrating trauma, stable or unstable patient, trauma in pregnancy, pediatric trauma, subacute trauma. The goal for the fast to identify fluid in location where it does normal, not usually beyond, and detecting also the visceral injury like liver, spleen, kidneys, also the vessels. Fast scan, you should know anatomy technique, fast demonstration, free fluid. Where can I see the free fluid? Free fluid usually appears anechoic by ultrasound, mean black in ultrasound. Accumulation in area of injury, overflow into dependent areas as pouch of Douglas, Marison pouch as reverse, varicoligator, and in thoracic cavity also. The fast anatomy depend sites right supramesocholic or merisome pouch, splenorenal recess, right precoelic gutter, right inframesocholic, left inframesocholic, also left precoelic gutter and pelvic cul-de-sac region. The consideration of technical issues, standards views we have for standard areas you can searching and exam it scan by probe ultrasound. Number one, right upper quadrant view. That is known as prehepatic or merisome pouch and right flank view. Three views in this area. The left upper quadrant view, also known as the pre-splenic region and left flank. Also, pelvic xiphoid view, right and left precolligator. This is the important region you can see on the image now. Technical consideration extend view. Sometimes you should to extend to other areas like pleural spaces view, anterior pleural space view, and parasternal view. This is not uh, equal fast. This is extended fast. Also, it is important to do that. The standard fast in this region, four region. This is the standard technique. Standard fuse number one, this precardium region or xiphoid subcostal region. Right upper quadrant, this is called Morrison pouch, pelvic cul-de-sac or Douglas pouch. Left upper quadrant, splenorenal and presplenic space. Extended view, this is called E-fast for pleural effusion. This is the region demonstrated on this patient. Number one, xiphoid or subcostal to see precardial area. Number two, right upper quadrant to see the merisome pouch if there is any collection in this region. Number three, this is the pelvic to see the Douglas pouch or cul-de-sac region. Number four, left upper quadrant. This is difficult in examination. Also in comatose patient, not move, fixed patient. In this area, the examination scan need experience from you. This region see splenorenal and presplenic spaces. Number one, the xiphoid exam or xiphoid area. Normal anatomy, you see no any fluid here, collection surrounding the pericardium region. Also, liver at free top of screen in this region. When do this demonstration by probe and angulation or angulate the probe toward the face of the patient. Epicardial fat versus effusion, thin layer anterior to the right ventricle, not present posterior to the left ventricle in this demonstration region or area. This is the number one xiphoid, as we said, to see this anatomical pericardial anatomical normal or abnormal. If there is any fluid collection, you can detect by this region, in this region. So this is the free four chamber of the heart. This is the pericardium. It is clear, no any fluid collection noted. Sometimes minimal fluid, normal physiological noted, less than 5 millimeter noted in this region. Number two, right upper quadrant exam or scan. This is the region and make probe like this, perpendicular, my mid coronal plane, just superior to the iliac crest in this region. This is the iliac crest, and you make probe superiorly and perpendicularly, probe facing and toward patient head. What you see in this region, you can see this anatomical imaging ultrasound B mode. This is the diaphragm brightness, and this is the liver, this is the right kidney, this is the Merisson pouch. The Merisson pouch in this region, it is anatomical normal, no any free fluid noted in this area. If a free fluid noted in this area, like the screen, black screen, you show here small or minimal or mild or moderate fluid collection in this region. So this nice to detected it or easily to detected this fluid in this region. If any fluid noted here, this or here, this is the pleura, this normal pleural space. If a black area or fluid collection anechoic in this region, this is pleural effusion, indicated pleural effusion. Number 3, pelvic exam or pelvic scan. You put the probe in this area. Also, you can two method to make probe in this pelvic region transversally, the longitudinally. To see what? To see the rectangular shape of the urinary bladder. This is the normal shape. If any deformity or laceration or any abnormality noted in or traumatic or contusion in the wall of the urinary bladder, you can see it and detect it easily by fast scan ultrasound. Also, this is the normal wall and no any free fluid noted in anatomical region in this patient. This is female. This is the uterus and this is the cervix. This is the vagina. No any fluid collection separated the urinary bladder from the uterus. No any fluid collection noted in the Douglas pouch or cul-de-sac region. So this is the normal anatomical appearance. You put it in your mind. If you see it, this is normal. If any abnormality noted in this area, uh, you can catch it immediately after this image when put it in your mind. Number 4, left upper quadrant exam. This is difficult area, so if patient not move, not take a deep breath, so this is difficult region and the difficult fast scan in traumatic or RTA patient, especially if the patient is comatose. This region see the spleen and the left kidney. This is the normal kidney, no laceration, no any contusion noted. So this is the appearance in B-mode ultrasound. This is the pouch separated the spleen from the left kidney. The spleen is normal, echogenicity normal, button ultrasound study now in this image, no any laceration, no any contusion noted. If any abnormality or free fluid noted in the splenorenal space or pouch, you can see or find like this screen an echoic black region or as rim or collection. You can suspect it mild or moderate according to your evaluation. Left upper quadrant exam, we we both probe, as you said, perpendicular, mid coronal plane just superior to the iliac crest. This is the issues of technical. You can do it easily in patient. If you know normal anatomical regions in 4 quadrants, in 4 regions, easily to detect any fluid collection or injury in the organs. This is the left upper quadrant. This is the spleen and the left kidney, as I said in the previous imaging. This is patient, and this is the marker number 1 to number 1, number 2, 3, 4. But the issues or the true, we put number 1 in xiphoid, number 2 in the right upper quadrant, number 3 in the pelvis, number 4 the last region left upper quadrant. This is the best uh, issues or best demonstrate this ultrasound scan. Fast demonstration, how fast is fast? Why? Or how? Less than 60 minutes, not more than 60 seconds, not more 1 minute. 60 seconds just to make all this region in 1 minute. Focused abdominal sonography in trauma reliability, there is sensitivity up to 91%. Specificity up to 99. It is very specific, but not more sensitivity than CT. The first, you can interpret first ultrasound study maybe negative or positive. Positive, you can find free fluid in any area from the 4 areas which mentioned previously, in pericardium, in Marison pouch, in splenorenal, in pelvic. This is called positive fast. The negative, no fluid in any windows. Intermediate, if any one of the 4 windows which mentioned previously is inadequately visualized. We have scoring system to do ultrasound or fast ultrasound. The scoring in lower volumes, fluid accumulated in the pelvis or near the site of the injury. It is not until there are larger intraperitoneal fluid volumes, more than 500 ml. That fluid is detectable in the prehepatic and presplenic spaces. Recent study shows that fast can detect fluid rings from approximately 250 ml to 620 ml. Modified scoring system, re-evaluated scoring system measuring the depth of the fluid in the depth pocket. But we suspect, or this is not measurable, but you can suspect if this is rim in the pouch, hepatorenal or splenorenal pouch. If rim, you can measure about 25 or more than 250 mil, approximately. Does fast make, sorry, does fast make difference in trauma management, and the fast make different for you in trauma patient management during primary or secondary survey? Yes. If patient hemodynamically stable, stable or unstable. If patient is stable, fast scan done. If negative, CT scan or observation. You can make admission for the patient and for observation. If the fast scan is positive, CT scan immediately. This in stable patient. In unstable patient, fast scan negative. طوالي كان in the previous diagnostic peritoneal lavage done by surgeon in the previously. Now not done, so it is mentioned here as traumatic patient in exam like this, but not reliable in real time now for searching guest. If the fast in unstable patient positive, laparotomy immediately should be done for this patient. The base, lack of the free fluid, no injury, not enough to see too early. Sometimes you make fast for the patient, but negative fast for observation after 4 hours or more than 4 hours, may be free fluid detected in follow-up by ultrasound. There is advantage of fast and disadvantage of fast ultrasound. The advantage for fast ultrasound is early to diagnose in resuscitations or emergency room immediately beside the patient. Rapid 1 to 2.5 minutes. This is the rapid scan for your patient. Repeatable, non-invasive, low cost. All this is advantage characteristic for fast ultrasound. What is the disadvantage for fast ultrasound? Difficult to distinguish. Type of fluid. Sometimes there is adopt or there is pitfall noted in some patients like cirrhotic liver with ascites, follicle rupture in females, sudden RTA or trauma done for this patient and brought to ER. When you do scan, you found there is free fluid. So this free fluid pitfall not related to the trauma, related to liver cirrhosis and ascites, to any systemic failure or rupture follicles in females. This is adopt you to make decision. Is this positive fast or negative fast? This is beautiful for more diagnostic beta, diagnostic and more diagnostic radiologist doctor. So what is the issues here? The issues, the clinical data and history. This is a guideline for the doctor to differentiate between pitfalls, radiologist or fast scan and negative positive scan really. Pitfalls, as I mentioned, limited pre-existing fluid collection. I said ascites, dialysis, pelvic fluid collection in female in rupture follicles, fluid filled bowel loops. All these pitfall misleading to false diagnosis in traumatic or RTA patient. The scan should be repeated during the secondary survey, and also if the patient demonstrated clinical deterioration since free fluid maybe have accumulated in the intervening time. The quality of image obtained may be also be limiting factors with patient obesity, gas in the bowel, leading to degradations in imaging quality, and subcutaneous emphysema in surgical, in traumatic patient or road traffic patient, non-mobile patient, and penetrating injury. All this is beers. Does fast replace CT? Unstable patient, positive fast, or stable patient, low force injury, negative fast. This lead to consider observation patient. CT is far more sensitive than fast ultrasound for detecting and characterizing abdominal injury in trauma. The gold standard for the characterizing intra-parenchymal injury in liver, spleen, kidneys, any solid organs, better by CT. Ultrasound fast just to detect it if any free fluid noted in this case. So this is serious case, urgently for CT if the patient is stable. Now, this is the report for report ultrasound for fast ultrasound for the negative fast patient. You make technical or techniques, clinical data, findings, no free fluid, no intraperitoneal, no. And this is the impression normal fast examination, no sonography evidence for of hemopericardium or hemoperitoneum, and recommended for IV contrast CT immediately if the patient is stable. If patient deteriorated, unstable, fast positive, for operation. Now we talk about free fluid. We finish the normal anatomy and the technique. of the fast ultrasound. Now I will talk about free fluid in abnormal or in traumatic patient. We starting by number one, the xiphoid region. This is the chamber for chamber heart. If to detected if any abnormality, yes, there is mild or slightly or minimal pericardial effusion fluid surrounding the pericardium. This is mild to moderate, not a REM. This is mild to moderate fluid collection in the pericardial region. This is pericardial effusion. This is the marker. If you show this, not forget this image, put it in your mind. Pericardial and pleural effusion. This is the pleural space. So this is pleural effusion noted in this area, and mild pericardial effusion also noted in this image. This is the liver and this is the kidney. We show in the previously there is normal area in the anatomical and normal negative fast, but here there is separation between the liver and the capsule or the renal space. So this is anechoic, not REM. This is mild free fluid noted in the rhizome pouch or hepatorenal pouch. This is the abnormal region or abnormal fluid collection in traumatic or RTA patient. Liver in this view or in this cut of ultrasound, no any abnormality, no laceration, no contusion. Also, you can make demonstration or scan the diaphragm. If any ruptured diaphragmatic hernia, can detect it during scan by ultrasound in few minutes, in few seconds. This is the liver, and this is severe perihepatic free fluid collection noted in this region. Also, you can see this is the liver, and this is the diaphragm, and this is the right kidney. This is Marison pouch, free fluid noted, and echoic free fluid noted in the hepatorenal or Marison pouch, and pre-hepatic region, moderate to severe. Hepatorenal, subhepatic, subphrenic spaces noted in this area. This is the liver also. If there is contusion in the left lobe of the liver, and there is free fluid separated the liver from the kidney in Marison pouch and prehepatic area, and some collection of hematoma noted in this view. This is an echoic free fluid surrounding the liver with some abnormality noted in the liver parenchyma. So this patient, if stable, needs CT with IV contrast to detect any laceration or contusion in the liver, also to detect any abnormality in the vessels. Right paracolic gutter in this region, you can see, yes, can see it in ultrasound. This is paracolic gutter, free fluid and echoic collection, and this is the bowel lobe. This is the gases in the bowel. So you can detect it in fast ultrasound immediately, easily, without any confusion. Fluid in the pelvis, this is the urinary bladder, and this is the uterus. This is the blood collection, mild in the Douglas pouch in seating of trauma case or RTA case. This is bowel loops, and this is fluid noted in this region anterior to the uterus. This is the endometrium, and this is the myometrium surrounding by free fluid. How to differentiate between bladder and this region? This is the bladder, triangular shape, rectangular shape, wall is intact. But in this view, when demonstrated ultrasound, you can see ultrasound in transverse and longitudinal view easily. And this is turbid fluid collection noted in this region. So patient if stable, immediately for IV contrast CT scan. Fluid in the pelvis, also this is the bladder intact, no any rupture or any laceration in the wall, and this is free fluid noted lateral to the adjacent to the lateral wall of the urinary bladder and in the posterior region. You can suspect or later not migrable, but it is you can said mild or moderate or severe according what you see in patient. Fluid in the splenorenal pouch, also this demonstrated in the last region. You can see this is the spleen and pre-splenic fluid collection noted in this case. And there is spleen, this is the spleen and this is the left kidney. There is rim of free fluid noted in this region. Mild to moderate left subphrenic, pre-splenic, splenorenal spaces, all these spaces uh, noted or surrounding with free fluid in traumatic case. This is the free fluid surrounding the spleen, and in this image also, or in this case, spleen intact here, no any laceration noted. Left pleural effusion, also you can see when demonstrated any region or any space during exam patient, you can see the right side pleura or the left side pleura according to your view. By one view, you can detected the organs, the free fluid. Yani in the left side, you can see liver, spleen, kidney in the same view, and can see diaphragm of and any laceration in the spleen or renal or diaphragmatic region, diaphragmatic hernia, anything you can see by fast ultrasound less than 1 minute. Now we change or move to the abdominal organ injury. Abdominal organ injury, you can detect it by fast ultrasound, but the main issue in the fast ultrasound to detected fluid. So we find fluid collection in any space that indicated there is organ damage or injury. Even not see any solid organ injury, that not mean this is intact. You can do IV contrast, maybe see or detected any abnormality, even minute. This is the protocol of gradient of solid organs. We have to check just for remember it, and if you write report, you can come back to the net, and from Radiopedia you can determine the degree and measurement of the spleen, renal, liver, anything not keep in your mind, just for remember. This is example for organic or solid organ injury, contusion or laceration like this. This is the liver laceration noted, contusion noted, not as the normal view or anatomy when demonstrated in the beginning of the lecture or presentation. This is contusion, abnormal, heterogeneous, hyperechoic region. So patient for IV contrast to determine and deter the grade of the laceration of the liver, if conservative or for surgery, according to the grading classification of the organ. Liver laceration and hematoma. This is ultrasound, and this is IV contrast selected cut at the level of kidneys, aorta, and right and left lobe of the liver, stomach, like this. This is laceration noted. No free fluid. Maybe this is rim, this stopped area. Not sure, but so there is contusion noted in the liver. So patient, if stable, immediately for CT. CT clear, obvious laceration noted in the IV contrast study for the of the liver. Kidneys normal, aorta also normal. Uh, Anything normal, but this is laceration. We put grading from demonstration from net, Radiopedia, or radiological assistant. This for doctor or radiologist, but of resident to not know this website. Splenic laceration noted in ultrasound. Easily detected this. In CT, also this is laceration. In ultrasound, in CT also, this other different cases. For example, to put this fuse in your mind, even in CT or ultrasound demonstration. Perihepatic and renal hematoma. This is renal contusion, and there is heterogeneity noted in the mid zone of the kidney, in the right kidney. This is laceration noted in the lower bowl of the right kidney. So patient immediately F stable for demonstration IP contrast CT. This is the report fast examination for positive fast technical technique probe demonstration probe. Which probe? In the fast you focusing on assessment sonographic technically areas mentioned 4 areas in the technique, and clinical data. You can put the gender and the issues of trauma or RTA. Finding there is evidence of hepatic laceration like this, free fluid and immersion. Positive fast ultrasound examination demonstrated multi-site free intraperitoneal fluid with solid organs injury, including كذا. Recommendation patient for CT, IPCT contrast immediately if the patient is stable. To conclude, fast ultrasound is a rapid bedside tool in trauma positive fast in unstable patient, as mentioned previous in the beginning of this lecture. That is urgent intervention. Thank you for your intention for everyone. Now for question.
شكرا دكتور، بارك الله فيك. دكتور حسين، بارك الله فيك على ما قدمت. نفتح باب الاستفسارات. Any question regarding the topic, please? You can write it on the Q&A panel. And Dr. Hussein ready to answer it, inshallah.
Yes, there is question noted. Can a negative fast include intra-abdominal injury? No. Fast has highly specific but limited sensitivity. A negative fast doesn't exclude injury. And CT scan, as I mentioned, required for clinical suspicious persist. Okay. Yes, there is other question.
Dr. Hussein, there is question in Q&A panel also. How to score a fast scan?
How to score fast scan?
Yes, it's written like this. How to score a fast scan?
Yes, I mentioned in the lecture, the scoring of the scan is determined scoring by fast or e-fast. It is generally reported as positive or negative, as I mentioned in the beginning of the lecture, with dimension dimension of which windows as positive. احنا عندنا 4 regions or 4 space. Which windows are positive? Right upper quadrant, Morrison, left upper quadrant, splenorenal, pelvic, pericardium, pleura. If needs a rough estimated fluid, small, moderate, large. Not but yourself for measurable or measurement. This is the big in measurement from دكتور. If you يعني بالعربي إذا أنت متفق مع السيرجونز في نفس الوحدة أو نفس المستشفى، على يعني معودهم على مقاسات ممكن تقيس. فاحنا قلنا اذا كان مثلا عندك 5 ملي، تمام، فال5 ملي تعمل 200 اكثر 250. ال ال الواحد ملي بيعمل اكثر 250 مل في الود. تمام. يعني اذا كان عندك 1 سنتي، معناه عندك آه، سفير في الود. فاحسن نعمل نحدد بمايلد مودريت سفير. اذا كان ريم نقول ريم اوف فلويد. اذا كان شويه كذا انت بتقدر بالنظر يعني بالعربي كذا، تحط نفسك في قياسات. ده الافضل. في واحد تاني سأل قال when should fast be repeated when. طيب fast should be repeated in unstable patient. كنا في in the beginning of the lecture. or when initial scan is negative. إذا كان السكان نيجاتيف وذي فورسنج تروما أو ار تي اي، طبعا المريض حيعملوا له ادميشن وحيكون كل 4 ساعات for repeat scan. ف this is initial or repeated scan in negative and for follow up also. يعني for conservative patient for repeated scan. اوكي. في واحد سأل كمان قال what is the rule of fast compared to CT in trauma. قلنا الفاست رابد beside screen tool، بينما السي تي is the definitive imaging modality for stable patient. واحنا قسمنا في البداية إذا كان stable or unstable من هو اللي يمشي للسي تي أو يمشي للفاست أو للأوبريشن immediately مباشرة. اذا كان البيشنت بالفاست انت بيسايد بيشنت بالتول بالماشين عملت فاست وطلع بوزيتيف، والبيشنت انستيبل immediately patient for OR no for CT. CT هنا lost time and lost life of patient. يعني الافضل يمشي للاوبريشن روم مباشره لابروتومي. لكن اذا دخلته سي تي بيحصل deterioration للبيشنت وmaybe lose your patient. اوكي. كلير.
في أسئلة ثانية على كيو أند إيه بانل دكتور، ممكن تشيك عليه، بارك الله فيك.
طيب طيب في سائل بيقول the question on the Q&A panel will be answered at the end of the lecture. خلاص يعني ده مجاوب عليه تقريبا. في أسئلة ثانية؟ يعني الانسر الكيو اند انسر كويشن كنا ذا اند زي ما قلنا، في أسئلة كذا جاوبنا عليها. دي انك انت ما في أسئلة ثانية خلاص. ما شايف حد سأل ثاني. طيب في أسئلة هنا موجودة كمان. السائل بيقول كان فاست promote to interventional more specific by fluid aspiration. طيب احنا السؤال ده اللي كان fast promote in intervention more specific by fluid aspiration. نعم. هنا more radiological focused or more radiology focused more intervention radiology phrasing. الالترا شورت تمام اللي هو الفاست one sentence for this answer promote اوكي يعني intervention promote technique. طيب في other question. So in trauma setting of patient can breathe well or there. Yes أنا جاوبت السؤال ده في الليكشر. البيشنت لما يكون unstable في difficult to do fast mainly in the left quadrant. There is difficult in the normal patient. So in traumatic patient, unconscious, not move, so difficult. But your training, by your training experience, you can detect it free fluid or organ injury. طيب. What about cardiac contusion? Cardiac contusion can detected in epigastric region or xiphoid region. When you see pericardial effusion, you can detect the contusion as the any organs. When detect contusion in the spleen, can detect in the renal, can also. This is depend on your experience and your hand. The ultrasound dependent person, not any يعني أنا مش زي الدكتور فلان أو الدكتور أحمد مثل الدكتور هنا ديبندنت تختلف يعني من شخص لشخص. ففي ناس عندهم أو دكاترة بيحب الألتراساوند عنده خبرة جميلة جدا بيجيب أي حاجة بيجيب حاجات لما تعمل رنين بتلقاها موجودة مش بس سي تي فهي ديبندنت. أوكي طيب how many mil of bleeding needed to be obvious in fast. قلنا if less than 20 200 250 150 يعني 250 you can detect it. Also ultrasound detected free fluid more than in pleura more than X-ray. X-ray need some technique to detect. If there is sometimes I detected free fluid in pleura in some cases in routine exam. When do X-ray, normal X-ray, but in ultrasound there is pleural effusion mild. So ultrasound is more sensitivity and more detected of free fluid in the patient. Okay. طيب في واحد يقول which better of fast, which better of fast should present of pericardium. ما قلنا الريجون of pericardium xiphoid process and facing the probe upward to the face of the patient. يعني برضه هنا لازم تكون عارف المانوفر و how to do technique to detect abnormality in this region or other region. طيب how much free fluid should present. ده جاوبنا خلاص كده جاوبنا الأسئلة كلها الحمد لله. إن شاء الله تكونوا استفدتوا بإذن الله. في حد عنده سؤال ثاني؟ أستاذ أيمن.
طيب بارك الله فيكم دكتور.
الله يبارك فيك. Thank you for
بارك الله
all.
فيكم دكتور حسين. شكل المايك عندي مشكلة فيه. بارك الله فيكم دكتور حسين، أسأل الله أن ينفع بكم وبعلمكم وبما قدمتم، والشكر موصول لكم أنتم زملائنا الأفاضل على حضوركم وتفاعلكم. وفي الختام أود أن أذكر الأخوة الحضور بضرورة تقييم اللقاء من خلال الرابط الظاهر أمامكم على الشات بوكس بإذن الله تعالى. ثواني ويكون عندكم الرابط. بس هو في مشكلة عندنا تقنية، بس ثواني.
Thank you all for your time, attention, and participation for you. إن شاء الله نشوفكم إن شاء الله في لقاءات أخرى، وشكرا لكم كثير والله.
طيب الآن الرابط ظاهر أمامكم، بارك الله فيكم، تقدروا تقيموا، تبدأ التقييم. دمتم في حفظ الله ورعايته، بارك الله فيكم جميعا.